Hey everybody, welcome back to Pathology. Today we're going to go through the transfusion reactions. So the most common reaction is the febrile non-hemolytic reaction, and this really is a common reaction. It's pretty treatable with just like some antihistamines, and it's a type 1 hypersensitivity reaction. So it's an urticarial allergic reaction triggered by the allergen in the donor blood and is recognized by the host immunoglobulin. There is a problem. It can lead to anaphylaxis, but that's pretty rare. One caveat we always have to pay attention to is the frequency of the reactions increased with the increased storage age. So it's best to use fresh blood. Type 2 hypersensitivity reaction is when the host IgG will recognize the donor IgA and have a immunoglobulin reaction. Type 3 is when IgM fix a complement, leading to the complement reactions. And type 4 is going to be your cell-mediated hypersensitivity reaction. And the risk will increase with the frequency of transfusion. It's caused by IgG. So when the B lymphocytes react to the IgM for the primary reaction, during the second exposure, the IgM will switch to IgG, and then that leads to a very strong type 4 hypersensitivity reaction. Okay, so we always have to be worried about rejection. So blood has to be tested for hepatitis B and C, HIV, HTLV1, Staph aureus, and syphilis because these are blood-borne diseases. So if we, implant an organ, the rejection is going to be characterized by a pale organ. So there's not going to be any blood going through it. So how do we prevent the rejection sequence, right? So first we will kill the T cells in the transplant. To prevent the graft versus host reaction, we have to purge the donor blood of all the complements. There is no rejections for corneal and cartilage transplants because these don't contain any blood supplies. So the rejection is always going to be your most serious reaction. There is thickening of the vessels, widespread capillary thrombosis and necrosis, along with amyloidosis with the continuous hypersensitivity reaction because of the constant, autoimmune reaction, essentially, right? So in acute rejection, there's going to be leukocytic infiltration, of course, because the leukocytes will be kind of responding to the invading pathogen in their head. So to prevent this, we want to match as well as possible, especially with the HLA classes 1 and 2 for the bone marrow transplant. We want to prevent the graft versus host disease, where the associated bone marrow transplant and stem cell transplant will have the donor T cells attack the host organs. So how do we prevent that? We will irradiate the donor blood and put the patient on immunosuppressants. Okay, so the ABO blood groups are the ones that is the most common. This is the one that we screen for, along with the RH factors. Wrong transfusion, wrong blood is going to cause the serum sickness, which is a type 3 hypersensitivity reaction. So it can also be caused by like antibodies from other species. So like old vaccines, they come from like animals, or any anti-venom treatment, like especially the older versions. This will cause the IgM and IgG to switch, and then you need CD40 and CD40L along with transcription factor beta to switch. So to prevent the switching, we can, filter the blood from these cytokines and give them a certain anti-A or anti-B reaction. So anti-A, there is a certain amino acid which is like NAGA, is associated with it, while an anti-B is galactose. So you can kind of test for that. But the theory is that anti-A and anti-B form from cross-reactivity from the intestinal flora, and that will stimulate the formation of the antibodies for these like blood cells after birth. Intravascular hemolysis is going to be due to the binding of the complement, and that leads to the destruction of the red blood cells in the wrong blood transfused. So first thing going to happen is jaundice, due to the unconjugated bilirubin, and then Coca-Cola colored urine and dyspnea. It's also going to result in splenomegaly, hepatomegaly, skeletal changes, all thanks to the unconjugated bilirubin and the lysed blood cells. The skeletal changes is due to the destruction and reabsorption of bone. So there's going to be destruction of bone, and then the bone's going to rebuild on top of it, but it's going to be not like ordered. As a result of the lysis of the red blood cells, the haptoglobin is going to be low, but the unconjugated bilirubin is high. That's going to lead to the hepatomegaly. There's going to be high LDL thanks to the liver not working, high urine hemoglobin. So the hemoglobin is going to be excreted along with hemosiderin in the macrophages. Okay, so the hemolytic disease of the newborn is basically due to Rh incompatibility, where the Ig antibody from the mother crosses the placenta. So it can lead to all of this. The most serious consequences is kernicterus and hydrops fetalis. We're going to test the blood using like the Coombs test, and we're going to prevent all of this by giving the patient's mother Rogam. Trolley is a transfusion-related acute lung injury, and that's when the transfused blood activate the neutrophils. The neutrophils are going to be primed and then activated by the MHC1 in the transfused blood, and they're going to attack the lungs. If the Trolley is suspected, we have to keep the transfused blood banks and get new blood. Multiparous women are most at risk, so women who've given birth several times, and is associated more with plasma transfusion rather than like blood transfusion. TACO is transfusion-associated circulatory overload, so it's more of a fluid overload, which causes the respiratory distress. So here's Trolley versus TACO. Important, fever happens in Trolley, but not in TACO. JVP is unchanged, while in TACO it can be changed. There is going to be a decreased response to diuretics, while in TACO there is going to be an increased response to your diuretics. So when patients start presenting with rashes and then the dyspnea, you want to check if they have hypertension, hypotension, fever, or no fever. So in TACO, all kind of blood components can cause it. It can overlap with Trolley. These things are not mutually exclusive. So we will prevent this by leukoreduction. We don't want to give too many white blood cells. Give diuretics and provide ventilation. Okay, so acute anemia is mostly due to decreased intravascular volume. So the results will be decreased oxygen, increased erythropoietin, and increased reticulocytes. Chronic anemia will result in the iron deficiency and the chronic blood loss due to some kind of GI lesion. That is the most common one, especially in older adults. Here are the symptoms. The ones are usually dizziness, dyspnea, fatigue. But those are really general symptoms. You want to see if the mucosa is very pale, and if they have a bounding pulse. So the red blood cells are going to be hyperchromic or normal chromic, and more importantly, the O2 transport is going to be decreased. They can be hereditary or acquired, and in the hereditary version, there's going to be a lowered capacity of the red blood cells to transport oxygen. So schistocytes are going to be your mechanically damaged red blood cells. They're called like helmet cells as well. Nucleated red blood cells are going to be immature red blood cells. Basophilic stippling of the cytoplasm is a pretty characteristic sign of lead poisoning. Teardrop cells are dacrocytes, are immature red blood cells that have been damaged coming out of the bone marrow. Acanthocytes are going to be in liver diseases, while sideroblasts are going to be in the bone marrow, and it is characterized by some kind of problem in iron metabolism. Spherocytes are going to be fragile cells, especially in a solution, because there is too much surface area versus a biconcave disc, and it goes to the right for the osmotic fragility. You use the antibody Coombs test to find the schistocytes, or the spherocytes, sorry. And those are characteristic in the Rh hemolytic disease, hereditary spherocytosis, beta thalassemia, or some kind of autoimmune anemia. Basically, hemolytic anemia is the destruction of red blood cells or a shortened red blood cell life, and it can be either hereditary or acquired. Both will result in the increased EPO thanks to the decrease in red blood cells, the accumulation of the hemoglobin degradation products. The extravascular hemolysis is going to be produced, or is going to be caused by macrophages, and that is going to decrease the haptoglobin, but not by a lot, just somewhat decrease the haptoglobin level. There's going to be anemia, splenomegaly, jaundice, and you treat with splenomegaly. The intravascular hemolysis is going to be destruction of the red blood cells in the circulation. So extra is always in spleen, really. But this is usually acute, caused by some kind of trauma, toxin, parasite, and it leads to the same kind of symptoms besides the bone marrow hyperplasia, actually. The haptoglobin concentration, on the other hand, is going to be much, much more decreased because the haptoglobin is going to be released from the hemolysis. So the hemoglobin is going to be released from the red blood cells, and then the haptoglobin is going to be formed, and then it's going to be stored in either the liver or the spleen. So with the storage, the levels are much, much lower. So like I said, it binds to the free hemoglobin to prevent the iron loss, but then the hemoglobin will oxidize in methemoglobin. The ferriheme will bind to globin, and the ferriheme will bind to the hemopexin converted into bilirubin, and then that can be excreted. But in the problems with this, with no haptoglobin, this is going to cause the renal hemosiderosis because, like I said, the heme has to be excreted, and pigment gallstones because the bilirubin isn't going to be converted. So extrinsic causes can be the hemolytic disease of the newborn, transfusions, or drug-induced. It can be mechanical. This is not really present anymore. This used to be when prosthetic valves were made out of non-biologic material. It can be caused by infections, burns due to the loss of fluid, lead poisoning, uncompensated bone marrow anemia due to some kind of cancer. So it's important to know that reticulocytes are immature red blood cells, and it only has to be, it can only be in the bone marrow. It's not natural for them to be outside the bone marrow. But if present in the bone marrow, it's a good sign. It means that the bone marrow is working. So in aplastic anemia, there's no reticulocytes, there's no splenomegaly. So we want to look for reticulocytes after like a bone marrow transfusion to see if the bone marrow is like taking. After transfusions of blood, you want to give the inocyne to increase the 2,3-BPG to prevent the oxygen trap. You give methylene blue to treat the methemoglobin in order for the ferritin haptoglobin complex to be excreted. And the microcytic hypochromic anemia is going to be caused by beta thalassemia, iron deficiency, lead intoxication, and anemia of chronic disease. Insidious bleeding, always think colon cancer, and it's going to present as these coffee ground stools. So in normal red blood cell breakdown, iron is going to be existing as ferritin and hemosiderin. Iron binds to the apoferritin to make the hemosiderin complex, and then that's stored in like the macrophages in the bone marrow or red blood cells in the blood. Ferritin is an acute phase protein, so it's non-specific. You can't really count on that for a definitive diagnosis. So you want to look at the evidence of increased hemoglobin breakdown, which is going to be a decreased haptoglobin because it has to bind, remember, to prevent the iron from being excreted, and the decreased hemopexin. Hereditary spherocytosis is found more in Northern European ancestries, and it's an autosomal dominant mutation in the ankyrin and the spectrin protein for the cytoskeleton. And there's a premature stop codon that's introduced, and it causes the cell to have an increased permeability to sodium. In the spleen, it's going to cause enlargement of the cords of Billroth where the macrophages are, so it's going to eat up all those cells. The macrophages are going to enlarge, and then it's going to cause like splenomegaly. The red blood cells are going to be increased in production, so they're going to be hyperchromic. There's no central zone of pallor. They're going to be filled with the Howell-Jolly bodies, and they're of course going to be very sensitive to the osmotic lysis. Because of the shortened lifespan, bone marrow is going to be working overtime, so there's going to be increased reticulocytes. They're really found with a positive parvovirus infection, so this is something that you always have to consider. How do we treat it? We want to give them a splenectomy. Aplastic crisis is due to a parvovirus B19, which infects the erythroblasts. So it's going to prevent the erythroblast from further developing. So it's not going to allow mature red blood cells to go around and do their job. It's fatal to patients on dialysis because the erythroblasts are too large to be passed through the dialysis machine. You treat this by giving the packed red blood cell. So as you can see here, parvovirus will invade the erythroblasts, and it's going to destroy them, causing a drop in hemoglobin, leading to a hemolytic crisis. So it's going to be a splenic destruction of the spherocyte, and it's associated with viral diseases. It can be severe, but it's usually pretty mild. But in severe cases, there's an increased amount of direct bilirubin. In bad cases, you want to put the patient on antibiotics and give them a splenectomy. And we want to prevent this, so be vaccinated. G6PD is an X-linked deficiency where there's a problem in deficiency in NADPH. There is a problem with the glutathione metabolism, and that's going to cause oxidant stress. And the oxidant stress is going to cause the intravascular and extravascular hemolysis. So combo problems in spleen and circulation. It's characterized by these bite cells where an oxidation of hemoglobin hemoglobin is going to be denatured, and then macrophages will take a bite out of those to remove the Heinz bodies, making the little Heinz cells, as you can see here. It's like a little cherry, and then they become Pac-Man. So the reduced haptoglobulin will bind to the free hemoglobin, and then there's not going to be any haptoglobin, and then that's going to lead to splenomegaly, etc., etc. So usually this is an X-linked deficiency, but it can be caused by the anti-malarial drugs, along with some kind of viral hepatitis infection, pneumonia, typhoid fever, favism especially. Not very common here in the States, but very common in the Middle East, and some kind of toxin. So in a recovery phase, there is going to be reticulocytosis. So reticulocytes are going to be in the peripheral blood. Or not in the peripheral blood, I'm sorry. It's going to be present in the bone marrow, sorry. Sickle cell, we've gone through this many, many times. It's going to be a point mutation causing fragile red blood cells. And they sickle in hypoxic condition and in decreased pH conditions. So this is prone to attacks whenever you're working out due to the lactic acid buildup. It's characterized by something called hand-foot symptoms, or syndrome, where there's painful ischemia in the hand and the feet. In bad cases, it can kind of continue or transform into the vaso-occlusive crisis or pain crisis, and that is going to be caused by the hypoxic injury and infarction in these organs. And those are going to be triggered by infection or dehydration and acidosis due to physical activity. There is going to be bone marrow expansion and secondary new bone formation. So the complication, of course, is going to be retinopathy, strokes, emboli, shock, dehydration, necrosis, priapism, seizures, and ulcers. These patients are really prone to Salmonella paratyphi infections, and that can cause osteomyelitis. They can be subjected to infections by encapsulated bacteria as well, and this is particularly problematic because these are really hard to treat. Sequestration crises occur in children with intact spleens, so we treat that with splenectomy, of course. The sequestration will also damage the renal medulla, and we treat them by giving the patients hydroxyurea and blood transfusion. Okay, so alpha thalassemia, there's a problem with the alpha globulin chains on chromosome 16. Beta thalassemia, there's a problem with beta chains on chromosome 11. In both, there's going to be Howell-Jolly bodies in the reticulocytes with the nuclear remnants. Those are called normoblasts. And there's going to be anisocytosis and polycocytosis. So there's going to be changes in the nuclei of the cells. Beta thalassemia is much more severe than alpha thalassemia, and there's going to be splenomegaly thanks to the problematic blood cells. They're going to, of course, get trapped in the cords of Billroth. So B0 is going to be the most problematic. It's not very compatible with life. Beta plus is going to be a reduced amount made. So it's going to make these under hemoglobinized hypochromic microcytic red blood cells. So the red blood cells are not going to have enough hemoglobin. There's not going to be a lot of heme or ferritin on it, so they're pale and they're going to be very small. They have these characteristic cells called target cells that have like basophilic stippling and fragmented red blood cells along with the target cells. Characterized by hemosiderosis thanks to the lysis of the red blood cell. So, of course, iron is going to be released and taken up by the macrophages. There's going to be a decrease in oxygen transport, and these are the signs: inflammation, cirrhosis, hypercoagulability, bone deformation, cardiomyopathy. And the signs would be growth retardation, heart disease, more importantly, DIC. Bronze diabetes is also a form of beta thalassemia, where there is going to be ineffective erythropoiesis. And the erythroblasts will die in the bone marrow. So no erythroblasts, no red blood cells being transporting oxygen, iron is going to be overloaded, and there is no hepcidin. So the hemochromatosis, the iron is going to accumulate and damage heart, liver, pancreas, and synovial joints, but more importantly, the skin. There's going to be pigmentation of the skin in places that don't see the sun. So think like, like the bikini area, places that won't see the sun at all, but they're going to be unnaturally dark. It also prevents sense with like hypogonadism. Patient, especially females, are not going to have menses. HFE is going to bind to the iron, and that's going to prevent the iron export from the macrophages. And there is going to be decreased absorption by the enterocytes in the duodenum anyway, so all of that is going to be just like so much iron overload. Affecting the pancreas, there's not going to be any insulin. Okay, so like sickle cell anemia, it's going to stimulate the bone marrow to remodel the bone, and it's going to make this fuzzy outline. So it's called a crew cut skull, and you're going to have like very, very prominent cheekbones. The cells are going to be basophilic stippling along with the fragmented red blood cells. So important to like kind of distinguish it from lead intoxication as well. So we give these patients the plaque red blood cells along with the iron chelators. But in beta thalassemia trait or minor, it's worsened by the iron therapy. So you only give them, you give them the red blood cell and a lot of iron chelators. So you don't actually give them iron. In other cases, you do give iron. So they're characterized by high ferritin levels. There's increased transferrin, along with a low or normal iron binding capacity and low serum iron. So there is low serum iron but high ferritin, meaning there's more storage in the bone, and transferrin, so there's more iron being taken out of the circulation and into the bone. We want to give these patients the red blood cells to prevent the growth retardation and the skeletal abnormalities, so we don't want this. So that's it for now. Thank you for your attention and good luck studying.